This is our star speaker, Professor Christopher LIU. He needs no introduction. He's one of the pioneers in ocular surface, and he does a lot of DMEK also. And I've had a privilege of listening to him earlier. He has some beautiful videos to share, and I'm sure he's going to give us some nice tips on how to deal with upside-down DMEKs. Welcome, sir. He actually deserves being called sir because he's been knighted. Am I right?
So if I may have my slides. Thank you, Dr. Rishi. I think this talk follows on quite well following Siddharth's talk on management of upside-down DMEK grafts. How do I advance the slides, please? So as you know, DMEK is a partial thickness graft whereby the desmase membrane acts as a carrier for endothelium and it is like replacing like. Correct orientation is really important, and that's already been mentioned, and it really depends on the desmase aspect of the graft facing posterior stroma of the recipient. And as was already shown by Dr. Rishi, that the graft always scrolls with the endothelium on the outside of the scroll. Indications, as you know, Fuchs's endothelial dystrophy, very good results. Bullous keratopathy, less good results because of usually some macular damage. And increasingly, we're also using DMEK to salvage a failed penetrating keratoplasty if the stroma is relatively clear and the shape of the PK or PKP is good. So we're just relining it to make it work. And you heard the tip to use a slightly smaller DMEK graft than the original PK, so it doesn't drape over the graft-host junction internally. Complications, of course, there's graft detachment, and the rates depend on the surgeon's experience, raised intraocular pressure, with some up to 3% developing secondary glaucoma. There is the possibility of IOL opacification, especially hydrophilic lenses, and especially following repeated rebubbling and raised intraocular pressure. Then we're on to upside-down grafts and other complications, as you can see further on the chart. So obviously this is upside-down grafts is an iatrogenic cause of primary graft failure, the other being prolonged surgery and mishandling of the graft. And this may be noticed intraoperatively and managed immediately, or postoperatively, and I will show you the signs, and then managed subsequently through a second operation. The incidence rates of upside-down DMEK ranges from 0 to 18%, and for sure it is underreported because it can be confused with other causes of primary graft failure, and also surgeons may not wish to report them having caused upside-down DMEK grafts. And currently there's no clear guidelines on the technique and time frame of its management. It does provide an exceptional challenge for the corneal surgeon once it has happened. The measures to avoid disorientation we have already heard about. You can mark with an F or an S or an L with a long and short arm. You've heard about that. You can use intraoperative anterior segment OCT, but that's not available for everybody. It is quite expensive. And also you can use the Mutsuri sign, which I will tell you about here. You can see on this diagram that if you put your cannula inside the scroll, then the silvery cannula becomes blue. Whereas if you're above the graft, then it still appears silver. However, this can fool you, so I can show you in a moment how this can give you a false Musiri sign. There are pros and cons of graft marking. I mean, it does add time, and the ink may smudge. There's the risk of the graft tearing if you use a peripheral mark, either an arrow or 3 asymmetric marks. And if you are to punch and in order to use an S or F stamp, you're damaging the stroma as well, and there will be wastage of material because the stroma itself can be used for a DALC. If you just use peripheral marking, then it can be not visible if the graft is slightly hidden underneath the peripheral cornea of the recipient, which can be a little cloudy. So here I want to show you in slow motion a false Musiri sign, whereby this actually is upside down. However, we are under the graft and we are manually opening it, but we've opened it upside down. Now the trick is, when you enter to the inside of the scroll, before you're underneath the flap, the silvery cannulae should remain silver. So that's how not to be fooled. Now here's a bit of a messy video. These are when we go back and look at our grafts which were placed upside down. So here again, with lots of air bubbles, which are a bit confusing, trying to open the graft, thinking that it's in the correct orientation and that the air bubbles are anterior to the graft, trying to open it. And then it wouldn't do that because, of course, it's actually upside down, and then going in with a cannula and fooled by a false Musiri sign. So what happens then once you have created an upside down DMEK graft? Well, it may not attach, and it may detach altogether. It may partially detach, and then when you look at the periphery, instead of the scroll going up like this, it may be going down like that, in which case you know it's upside down. There may be persistent corneal edema, and it's really important to video all your surgery because you can always go back and look and see. So if you review the surgical video and collate that with the anterior segment of corneal OCT findings, then you can confirm the diagnosis, and then you have to decide, what am I going to do? Am I going to use the same graft and turn it upside down? Or am I going to just take the graft out and put a new one in? The advantages of reorientation: it's more economical use of donor tissue. Theoretically, it reduces exposure of further corneal antigens to the recipient, and theoretically it diminishes the risk of introduction of infection from a further donor source. Also, if reorientation doesn't work, then you can always do a new DMEK. But of course, that would mean a third procedure rather than concluding the matter with a second procedure. And we've already heard, especially in private practice, patients don't really like this sort of thing. So if you're going to reorientate, then you stain the graft within the AC intraocularly. Also, if it's already detached, you can actually explant it, stain it, and reinsert it. But note that there will be a risk of endothelial cell loss with this particular option. So timing. Timely intervention will be crucial, as there is no evidence as to how long the graft can survive in the upside-down orientation, along with incidence of stromal scarring. So according to studies, viable endothelial cells may remain even after free-floating in the anterior chamber for 2 weeks. However, I would give you a caution that if you rebubble or tamponade with SF6, you can actually make a graft stick upside down, in which case the cells may be heavily damaged. And if you had done that, then maybe it's better to do a repeat DMEK graft. So surgical steps, as we've talked about, trypan blue should be administered into the anterior chamber to stain the primary DMEK, which is upside down. So you'll be staining on the Descemet's membrane side. However, if it is attached, So restaining should be done prior to detaching the DMEK graft so that you don't stain the recipient stroma, causing confusion. And you can attempt to detach the graft by injecting BSS through the side ports. So the remaining part of the talk, I will be concentrating on how to detach a partially attached or fully attached graft. So here we are using jets of BSS to detach an upside-down graft. And here we can also use an air bubble to help detach the graft. So firstly, an air bubble. Now this separates the graft and the recipient stroma, and then it creates space for you to use jets of fluid to displace the rest. And also you can use the air bubble by brushing it from above to detach the rest of the graft. So just to summarize, if still partially attached, you can create vent incisions as well over the area that is detached. Jets of BSS can be used, and if all attempts fail to detach the graft atraumatically, consider repeat DMEK. This is the final several seconds of video. I would appreciate if you let me show it without the alarm, etc. So here is the bubble, and the vent has been created, and the air bubble was protecting the graft, and you can use that to put jets of fluid in to detach the rest of the graft. Okay, so there you are. We have reviewed all our upside-down DMEKs, and it's being published, and you can see it in a few weeks' time. Thank you.
Professor Liu, could you just share how were your outcomes of these cases? How many of them finally failed? And did you see a lot of endothelial loss when you did the speculars later?
Yeah, okay, so I can't remember the exact details. There were 5 cases altogether, and 3 survived in the medium to long term, and the other 2 didn't and had to have repeats.
Okay.
Thank you.
Thank you. That is a very interesting talk. Thank you.